Hello, my name is Dr. Yaariv Khaykin. I'm a cardiac electrophysiologist at South Lake Regional Health Center and PACE Cardiology.
And it's my pleasure today to talk to all of you about some new developments that we as a program have been at the forefront of, namely left atrial appendage occlusion technologies for patients with atrial fibrillation. So I will discuss the physiology of atrial fibrillation. We'll talk about rationale for placing a left atrial appendage occluder device, and then discuss experience kind of in the world and at South Lake. So without further ado, first I wanted to kind of set the context. I'm sure all of you know about atrial fibrillation, the most common arrhythmia, but I wanted to sort of dive in and tell you a little bit more about the mechanism of the arrhythmia. And I'm certainly hoping that this movie was running just before we started, and it's still running. Very good. All right. Let me see if I can get a laser pointer here. There we go. So in your heart, you have four chambers, two chambers on top, right and left atria, and two at the bottom, right and left ventricles. I don't see any plumbers here, but as an electrician, I'm more interested in the electrical conduction system of the heart. Electrical activity in the heart normally starts in the sinus node. It's a group of specialized cells at the top of the right upper chamber of the heart. It generates a heartbeat, slower when you sleep, faster when you're trying to run away from a tiger. It activates the upper chambers to contract and push blood through the valves into the bottom chambers. Upper and lower chambers are insulated from each other except for a conduction wire called the AV node, taking electricity through this yellow Purkinje system down into the bottom chambers, making them pump quickly to the lungs and throughout the body. And normally, for every beat in the upper chambers, you have a beat in the bottom chambers. Now, in atrial fibrillation, the picture is very different. What happens in atrial fibrillation is you get short circuits and extra discharges coming from the pulmonary veins. Pulmonary veins are these tubes here, the back of the left upper chamber, left atrium. They drain blood from the lungs back into the heart. And where the veins plug into the heart muscle, that area is very irritable. It can become more irritable if you have electrolyte problems like low potassium, low magnesium. It becomes irritable in patients with diabetes, high blood pressure, people who are overweight, sleep apnea, alcohol, caffeine, dehydration, and multiple other conditions. And when they become irritable, they start firing these extra beats. And I tell patients, it's like somebody throwing matches towards a can of gasoline. When you have one of these beats come out, it can throw the rest of the heart into this rapid, irregular rhythm of atrial fibrillation, where the upper chambers start going at 300, 400, 500 times a minute. Now, when the upper chambers go so fast, they stop pumping. So blood doesn't circulate properly. The bottom chambers essentially have to suck the blood out of the upper chambers. And with that, a blood clot can form, particularly in the left upper chamber and particularly in the left atrial appendage, this cul-de-sac right here. And there are certain risk factors like high blood pressure, being older, having diabetes, having had a previous history of a blood clot that makes somebody more likely to suffer that consequence. The other problem that happens is all of a sudden you have a really rapid rate in the upper chambers, and all of these beats are bombarding the AV node in between the upper and lower chambers. And now AV node starts conducting a lot of those impulses, and the bottom chambers start going really fast. And when the bottom chambers start going really fast, some people, doesn't seem to affect them at all, they feel perfectly fine, but a lot of people, the ones that kind of subselect themselves and actually come to see us, feel really unwell. The younger patients feel the irregularity in their heartbeat. They feel out of control, drives them bananas, stop them from doing whatever it is that they would otherwise be doing. Older patients come in feeling short of breath, tired. They think it's their age. They just can't do whatever they were able to do before. And miraculously, in a lot of those patients, when you control the arrhythmia, they feel dramatically better. The other thing that happens is if the bottom chambers see, and in some people, just an irregular rate over a long period of time, and in some patients, the rapid rate related to atrial fibrillation over long periods of time, the bottom chambers deteriorate. They malfunction, and the patient can develop full-on heart failure, fluid on the lungs, etc. And we frequently see these patients admitted through the emergency room. They were kind of asymptomatic or saw that they had a pneumonia, they come in, they're short of breath, they're coughing, and we see that their heart muscle function is half or a third of what it should be. They're in heart failure and they're in atrial fibrillation with a heart rate of 150 beats per minute all the time. So atrial fibrillation is very common, affecting close to 1 million Canadians, and this slide is relatively old, so the number is probably higher, particularly as the population is aging. The likelihood of somebody over the age of 40 to develop atrial fibrillation is 1 in 4, and in the population over 80, about 10% of those over 80 have atrial fibrillation at some point in time. Now, there are medications that are used to thin the blood to prevent stroke. There are medications that control conduction through the AV node to slow it down. There are medications that we call antiarrhythmics that help control the rhythm and keep somebody in rhythm. Unfortunately, those are only about 30 to 40% effective over time and not the focus of what I'm going to be talking about today. We already talked about the fact that atrial fibrillation does pose a significant risk of stroke to these patients. It's a 5-time increased lifetime risk of stroke, more so in patients with non-valvular atrial fibrillation, and it's an independent risk factor for mortality. We know that aspirin doesn't do a heck of a lot to prevent stroke. Warfarin, I don't know how many of you still remember warfarin, but warfarin has been used for years to prevent stroke in these patients. It's a pain to use. You cannot have your salad and a glass of wine with it, causes problems. And we know over the last number of years that NOACs no longer novel, so DOACs, so direct oral anticoagulants, further improve protection from stroke in these patients above and beyond warfarin, as well as reducing the risk of bleeding in general compared to warfarin. But there is still a bleeding risk with these patients. Patients still need to be compliant with these medications. If you don't take them or you take less than you're supposed to, you decide to only take it in the morning instead of twice a day, they don't work, or they don't work as well, and they are still expensive, and doing surgery with those drugs on board may be complicated. So again, this slide kind of nicely illustrates the clot in left atrial appendage and what that clot looks like if you take it out, and what it looks like to our transesophageal echocardiographers is something that we want to prevent or eliminate. And so patients who cannot be on blood thinners for whatever reason, they do have other options. One option is patients who are going for surgery, any type of heart surgery, can have the left atrial appendage sliced off. It does add to the surgery. It increases the risk of bleeding. But in the large LAOS 3 study, which Kevin Teo from our center led, it showed that taking the appendage off in patients coming in for other heart surgery further prevents them from having a stroke. Some of those patients continued blood thinners, some didn't, but in general, it helped prevent stroke above and beyond baseline medical therapy. As an alternative, we can also put a little plug into the left atrial appendage through the catheter called the left atrial appendageal occluder device. Again, not without its own risks, but at least it's minimally invasive. It can be done by itself or at the time of AF ablation, because a lot of those patients are essentially the same patients. There are 2 devices on the market, Amulet from Abbott and Watchman from Boston Scientific. They are slightly different devices. So Watchman, a lot of people refer to left atrial occluder as Watchman because it was the first device on the market. It's kind of like Band-Aid or Kleenex, of left atrial appendageal occluders. It's a 1-lobe device. It's folded in the catheter. I, push it out of the sheath. It opens up into a little ball. I position it, and then under fluoro and transesophageal echo guidance, I release it, and then we see whether it sort of meets the various deployment criteria before we call it a day. The device has a bunch of struts that keep it in place. Those struts have little mini hooks on them that are about 0.5 millimeter deep that keep it from popping out and moving out of the appendage. And it's covered by special fabric that's supposed to minimize formation of blood clot and generally is able to do that. The Amulet device from Abbott is a slightly different design. It has a lobe, which is not dissimilar from the Watchman. It has hooks that are about 3 times as big as the ones on the Watchman. So Watchman is about 0.5 millimeters. On the amulet, they're about 1.5 millimeters. So slightly larger hooks. And the reason they're larger is because there's also a disc that gets deployed and covers the opening of the appendage, kind of like this. So the lobe keeps it anchored in the appendage, and then the disc covers the opening of the appendage. And it's important because of different appendageal anatomies. In some anatomies, when you put in a Watchman, you can get a shoulder, or you can get a little kind of crevice that Watchman doesn't cover. But if you put an amulet into those patients, the disc essentially covers off the opening of the appendage really nicely. And it's good to have both devices available. We have both devices available. We've been putting amulets in for about 7 years, and Watchman devices for about a year and a half or so. For whatever reason, the companies that are in the industry really think grocery shopping whenever they look at either shapes of the appendageal occluders or shape of the appendages, cactus, chicken wing, cauliflower, there's a marshmallow shape, et cetera, et cetera. We visualize all of those with pre-procedural imaging, typically CT and TE, where we can take measurements of the appendage, we can appreciate the orientation of the appendage, and using specialized software, we can actually see what the device would have looked like in the appendage and help us select the right device. And again, it's important to note that the size and shape of the appendage is very different, and so some appendages are better served with one type of device, some with another. There's also a number of different sizes of the device. Amulet goes a little smaller, Watchman on the other side goes a little bigger, and there's obviously a lot of overlap. Again, when we put it in, we have fluoroscopy, contrast, transesophageal, or intracardiac echo. We can see the sheath with a little ball being deployed in the appendage. We release the lobe, then we pull open the disc. We keep it open to make sure that the device doesn't come back, that it's firmly set in place, and then we release the disc, and that's kind of the final look on transesophageal echo and on fluoroscopy. Clinically, across a number of studies, the efficacy for stroke prevention between oral anticoagulants and the appendageal occluders has been roughly about the same. So you get the same bang for the buck in terms of preventing stroke. And obviously, since you're able to stop antiplatelet and anticoagulant agents in these patients, the risk of bleeding in the long run is substantially lower. Obviously, it's an invasive procedure. It does come with its own significant risks. You can see that from the early generation, the success rate of deploying the device using multiple different sizes and different size types of appendages has gone up from 90% to 98%. And the complication rate across multiple studies and across registry was about 2%, when you combine multiple severe complications of this device. Now, the more recent data this comes from the most recent registry of the Watchman device. The risk of complications is down from 2% to about 0.5%. A head-to-head study between amulet and Watchman essentially shows that from the point of view of stroke or death, major bleeding, and thromboembolic events, the devices are essentially equivalent. And the main indication right now are for patients who are at increased risk of stroke or systemic embolism, who would otherwise be on anticoagulants, but cannot be on anticoagulants because of significant risk of bleeding, and where we need a non-pharmacological way of managing and preventing it in these patients. Patients in our case are referred through the heart rhythm triage office, not through structural heart disease office. They get a pre-procedural TE and more so CT scan to get a better understanding of the appendage and its proximity to the pulmonary artery. The patients typically need to be on at least one antiplatelet agent before the procedure just to make sure that they can tolerate it. And then after the procedure, we try to keep them on 2 antiplatelet agents. But to be honest, most of the patients we've been getting are so frail and so prone to bleeding that we've done these procedures without any blood thinners before or antiplatelet agents before or after. We do typically give them a bolus of heparin during the procedure while we're actually deploying the device. And we get a transesophageal echo 2 months afterwards to make sure that there are no issues related to the device. We're also currently one of the centers enrolling into a study called LAOS 4, follow-up to LAOS 3. As I mentioned, LAOS 3, Kevin Teo's study, was a surgical left atrial appendage occlusion on top of regular medical therapy. LAOS 4 is a study where we're looking at patients being randomized, patients who can be on blood thinners, getting randomized to blood thinners with or without a Watchman device. And the rationale for that is that looking at multiple studies and registries, patients with CHADS VASC of 4 or greater, even though they're on blood thinners, still run a residual 10% risk of stroke over the next 5 years. And so we're trying to see whether or not we can reduce that risk of complications. So if you have those patients, generally speaking, CHADS VASC score of 4 or greater, they're on blood thinners, they're tolerating them well, please consider referring them to Lynn at the back of the room for the LAOS study. Now, just before I conclude, a little intro into what may potentially be coming. There are a number of companies that are looking at alternative devices for LAAO. This is a company called Laminar, which was acquired by Biosense Webster, and it uses this torture-looking like device to put it into the appendage and to essentially use the bread bag technique to twist the appendage off on its stalk and then lock it in place. So apparently it's safe, so they say. There are clinical studies with this device. And yeah, there you go. So we don't have that yet, but clinical studies are ongoing, and this or some of the other type of device designs may be coming to Yaariv Lab in the near future. This is in a cadaver heart, just to show you what that looks like. I think they'll show you from below in a minute what that appendage looks like when you twist it on and off. And there you go, there's an appendage being twisted on. Doesn't look safe, but apparently it's safe. In any case, so AF is the most common cardiac arrhythmia, heart failure, quality of life issues, embolism, very important complications. Despite improvements in anticoagulant, we still have issues with some patients not being able to take them and suffering complications. And so LAAO is the way to go in those patients, and looking at our various research studies, potentially in other patients as well. And then I'm going to bring this up. This is a QR code that links to a microsite that we developed with some patient education resources for our patients. All right. Well, thank you very much.